Okay, 8 o'clock on the dot. Good morning, everybody. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and it's my great pleasure to host this morning's Pediatric Grand Rounds on ethics, ethical duties and resources in the pandemic. About 2 weeks ago at the Department of Pediatrics town hall, when people were submitting questions, somebody asked me about how would be handling some of the ethical dilemmas around allocation of resources. I emailed David Magnus to ask him, and Alyssa and Holly, and discovered not only have they been thinking about disaster planning for well over a decade, but there already was a lot of great work going on. So great pleasure and to introduce them this morning. Before we do that, I want to point out the great agenda for upcoming Pediatric Grand Rounds. For the last month now, every topic has been COVID. We've touched on research, advocacy, community engagement, ethics. Next Friday, it'll be about optimizing education, a lot of the innovative work that Becky, Haley, and Carrie have been doing. We'll then have our patient safety lecture, Improving Central Venous Lines at Packard. And then in the following weeks, we'll talk about some of the ways telemedicine is being used for the tripartite mission. Examples with Natalie Pagler-Ceylon and her team will talk about clinical research, education, advocacy applications. And then in following weeks, we're teeing up some presentations on some of the great work some of our faculty are doing at statewide and beyond. And then we'll bring Bonnie back to give us an update on some of the interesting science and the things that we've learned just in a few short weeks. So with that, we'll move ahead. So I'll just say real quickly, David's the director of the Stanford Center for Bioethics. He's the Thomas A. Raffin Professor of Medicine, Biomedical Ethics, and Pediatrics. He's director of the Stanford Center for Biomedical Ethics since 2003, editor-in-chief of the American Journal of Bioethics, a member of the Ethics Committee for Stanford, vice chair of the IRB for the NIH Precision Medicine Initiative, all of us, many other important accomplishments. But in the interest of time, David, we'll let you take it away. Thank you for joining us.
Okay, thanks very much. Alyssa, next slide. We have no disclosures. Next slide. You can see the educational goals and objectives that we've got here. Hopefully learn both about theory and then how to apply some of the theoretical legal issues to deal with issues in allocation of resources in a pandemic. Next slide. So today we're going to be starting off talking about more theoretical ideas, and no better way to start than with Aristotle, which is the formal principle of justice, which is that like cases should be treated similarly, and you can treat different cases differently. In other words, if you're going to treat two different patients differently, then there must be a morally relevant reason that differentiates the two and justifies treating them differently. Next slide. Actually, allocation issues are obviously ubiquitous in society, but they're also ubiquitous in healthcare. In several different areas, the same kinds of issues that potentially might arise in case of a ventilator shortage already people are used to dealing with and have been grappling with. Those include organ transplantation, where we just don't have enough organs, drug shortages, especially around pediatric oncology drugs, where there have been shortages, expanded access programs with drugs that look like they work but are awaiting FDA approval, but there are more people who want to get access to those drugs than there are drugs available. All of those are different examples where allocation issues have arisen, and the principles and theories that we're going to be talking about have been used to apply to how to solve those different issues. There are three main theories of distributive justice. Utilitarian ethics says that you should maximize the total amount of net good. And there's some debates in the literature about how to define what counts as a net good. Some people define it in terms of number of lives saved, some in terms of life years saved, and you'll be hearing some more about that in a little bit from Alyssa. The number of quality adjusted life years, and again, these are all, and the idea there is to maximize the total amount of good. A second theory is egalitarian theory, which really focuses on equity, treating everybody equally, There, instead of trying to get the most bang for the buck and produce the most lives saved or the most life years saved, you really treat everybody the same way without taking that into account. So first come, first served, or a lottery would be example of egalitarian approaches to distribution. And then there are prioritarian approaches to distribution, which basically say that there are certain individuals who get to the top of the queue who should be focused on, for example, focusing on the youngest patients or focusing on whoever the sickest is. And as I mentioned earlier, in transplantation, all of these things, all of these different theoretical approaches have been balanced in different ways for allocating resources. So whether that's maximizing life years saved and some of the changes to the kidney allotransplant programs, the focus on sickest first for liver transplants, or using wait times, which was the earlier approach in some of the kidney transplant programs. Next slide. The prioritarian system and the idea that you would give a special weight to the people who are the most vulnerable comes from a very important work called The Theory of Justice by John Rawls. It points out that a just distribution is a function of a fair procedure. So if you have enough chocolate cake to divide between two people, one person cuts and the other person chooses, is a fair process of allocation. And Rawls asked the question, how would we allocate resources? Well, what we would do is figure out what people would decide if they didn't know what their own position would be in society. If they were behind a veil of ignorance, they didn't know what their race or gender or religious preference or education level or socioeconomic status was, what kind of society would they set up and how would they allocate resources? And on that basis, Rawls, next slide, justified two things that are lexically ordered as the primary way in which we ought to allocate resources. First, when you're allocating goods or resources, there needs to be equality of opportunity for all in the attempt to try and get those goods. And second, that when you are allocating those resources, a prioritarian approach is justified because you could justify diverging from equality only if it benefits those who are worst off. When you don't know where in society you're going to be, you'd want to make sure that since you might wind up on the bottom, that you focus on the people who are on the bottom, the poor, the disabled, and individuals like that, the people who are sickest, the people who are in greatest need, that really gets extra priority. Next slide. In addition to these broader theoretical considerations, which absolutely have been utilized explicitly in all these other allocation decisions, as well as in thinking about allocation of resources like ventilators and emergencies, there are a more specific set of principles that the then Institute of Medicine, now National Academy of Medicine, have identified as really important in these kinds of critical emergencies, and that have been very influential in a lot of the thinking and a lot of the planning that's been going on. There are four substantive principles. Sorry, before I get to the principles, there's a framework for how to think about this, which is first, there's conventional care as usual. Then as things become scarce, we have contingency care in which we do things differently, but the care is the same. And then what we're going to be talking about for the rest of the day is really what happens in what's called crisis care. What happens when you have severe resource limitations requiring significant alterations to standard care and rationing of resources. Next slide. And then these substantive obligations or duties that the IOM developed, as I mentioned, the substantive obligations include fairness, that differences should be due to objective differences in outcomes rather than things that should not be taken into account, including disability. The duty to care, that there is still an obligation to be responsive to the needs of patients and populations, which obviously need to be balanced with the utility considerations and the obligation to be good stewards of scarce resources. Next slide. Then there are four process obligations that have been identified. Transparency, that there needs to be public disclosure and engagement about the design and decision making. And I will say that the early efforts that we made in developing our initial plans for triage in an emergency, which we completed in 2007, did include a significant amount of public input and disclosure through the county health authorities in the area. There also needs to be consistency so that the rules are applied uniformly, regardless of issues like social work or other irrelevant criteria. The responses need to be proportional. Public and individual responses should be commensurate with the scale of the emergency and the degree of the scarcity. And then finally, there needs to be accountability in which individuals and institutions making and implementing policies and decisions should ensure that there's adequate oversight for any decisions that wind up being made. Next slide. So I'm going to now turn, we're going to turn from these theoretical considerations, which I just want to emphasize really do play a major role in thinking about how we're developing the particular systems of allocation. But you're going to learn now about some of the ways of which this winds up working out in practice. And I'm going to now turn it over to Alyssa Burgart, who is a pediatric anesthesiologist. She's also chair of the ethics committee. She's part of the Center for Biomedical Ethics and a researcher, teacher, and clinical ethicist at the center, as well as at Stanford generally. Alyssa?
All right, thank you, David. So I'm going to focus on taking this issue from the theories that David has discussed into practice, as well as talking about some of the legal frameworks that really implicate this work. In the public sphere, you've likely seen a lot of articles that look like these ones, which have to do with the fear that is emerging from clinicians about the decisions that they might need to make, as well as what is the space that clinicians may need to make these decisions, not only ethically, but also legally. So the first thing I'll talk about is this issue of legal immunity. There are concerns that even though a medical standard of care should be local and should be flexible, that legal standards of care may not follow implicitly. And so there's this idea that what we need to have in order for clinicians to continue to present to work, for volunteer workers to present to provide healthcare services, that they need some sort of legal protections that will protect them from litigation. One of the things that was included in the CARES Act, which was just signed on March 27th, 2020, included a provision for volunteer health professionals granting them immunity so long as they were providing healthcare services, they were working as a volunteer, and they were working within the scope of practice as defined by the state, and that they were providing this care in good faith. There's a New York executive order that went into effect March 7th. This provides immunity for all healthcare workers, really with the exception of gross negligence, that these healthcare providers are immune from civil liability for injuries and deaths. It also really causes minimal record-keeping requirements, so some colleagues in New York are pleased to not have to do quite so much charting given the burden of the work. However, the opportunity to use litigation as a mechanism for the public is pretty important. And so if you're going to grant immunity to clinicians, it's really important that this is done in a thoughtful way. And so there is concerns about what about people who are practicing outside of their scope of practice, or what if someone commits a crime? And those things may still take additional work in terms of determining them. And additionally, I think it's very important to recognize that even in a crisis standard of care, there are many very important healthcare obligations that clinicians have to their patients that do not disappear. We still need to accommodate patients with disabilities. We need to ensure that we have safe practices to the greatest degree possible. Informed consent is not thrown out the window. We need to provide informed consent whenever there's a possibility to do so. And we still need to respect the patient privacy rights. There are many other legal issues that come up in standard crisis care. I'm not going to cover all of them. In general, though, there are these themes in terms of who are the types of personnel that are included, what does this do to staffing ratios, for example, in a licensed hospital, who has access to treatment, what are the implications for EMTALA and other things that would guide who would have access to the hospital, making sure that we have access to PPE so that we have a healthy workforce. This also has to do with licensing for beds, coordination of services, so who's going to be able to volunteer, who's going to make sure that the knowledge is passed along across the organization. And then allocation, which we'll talk about explicitly. In addition to the guidelines we'll provide, there's this issue of what work does government need to do to ensure that hospitals have as many resources as they need. So for example, there are some governments who are considering seeing ventilators as a community resource rather than a hospital-based resource. There's also issues of liability that are different than those for individual clinicians. So if a organization simply failed to plan or train for an emergency, what liability would they potentially have? There's also issues of reimbursement, especially with changes in documentation. And how is it that states and countries can cooperate to make this work possible? The goal of crisis guidelines is supposed to be something that's practical. It's something that an earthquake strikes, or there's a fire, or there's a mass casualty, and you can use this tool in a timely fashion. One of the things that's been interesting during this pandemic is that because of things like social distancing, because of other work that's being done, we have had the luxury of time to try to think about these issues more deeply. Because certainly when Stanford was coming up with their guide about 10 years ago, they were really thinking much more about a mass casualty event different than a pandemic. So crisis guidelines kind of help you figure out, how should I think about the various patients who come to me? How might I organize those patients? And they only are in effect during times of extreme austerity. They're only when the hospital is overwhelmed. They have to be explicitly activated. The aims of these guidelines, they cover typically 4 main areas. So what is the framework for allocation? How are we thinking about this framework in an ethical way? In terms of structure and process, who's on the team? Who's making sure the team's doing what they need to do? How do we deal with ties? How do we deal with when should a patient, for example, be reassessed if they have been maybe not received certain critical care resources? When might they be reassessed and potentially get access? Legal issues, as we've touched upon, and also this issue of appeal. Is there an opportunity to appeal or not, depending on the type of crisis? And again, this issue of transparency that David touched upon earlier. I'm going to focus on, there are many, many different guidelines. Our group's been looking at dozens and dozens of guidelines from around the country and around the world. We're going to focus today on the Pennsylvania plan and the Maryland framework, primarily because these two have just been adopted in various forms by more governments, and so we just want to make sure that we have an opportunity to see what their similarities and differences are. So one of the things that Maryland did, and Pennsylvania did something similar, they had 15 community engagement sessions where they tried to figure out what are the things that are meaningful to the public, what are the things that people who are stakeholders in this process would find important. And so these are very similar to the issues that David brought up in the first part of the presentation, which is how do we deal with these various ethical principles, and how does that work out in terms of who should receive, for example, a ventilator. So you see very similar ideas in terms of what is a fair chance of receiving treatment. So again, that idea of first come, first served versus a lottery. And then there's these ideas about prognosis. And there's a lot of debate about whether you should include only short-term prognosis, your likelihood of surviving the current illness, versus long-term survival. So should we be taking into account the likelihood of a person living for 10 years or 20 years or 30 years? There's additionally this idea of life cycle. So people who are young might be prioritized over people who are older because they've had less opportunity to live their life. And there's also this idea that there are certain people who might be more valuable in a pandemic, such as healthcare workers. And so there are some plans that give priority or extra points to healthcare workers in particular. Just for those of you who may have seen the paper by Zeke Emanuel and colleagues recently, it covers very similar ideas to what came out in that community engagement process through Maryland. So when you look, for example, at the Pennsylvania plan, it really gives you a guide of how should we be thinking about this. When do we move from that conventional situation where we have our normal bed capacity, we have maybe some limited resources, but not severely? When does it become a contingency? And at what point do we actually move into a crisis standard? Both of these documents outline who it is that should be on the triage team. And so the triage team is the group that's going to be taking the tool and applying it to patients and determining who should get priority. So in Maryland, that triage team includes a triage officer. It has to have an experienced critical care nurse and also one additional clinician who has some sort of relevant education around that particular resource. So in a pandemic, you might include someone from infectious disease. In trauma, you might include like a trauma surgeon or someone else. In Pennsylvania, they actually have a slightly more complicated set of who's supposed to be provided, and those members of that team can include additional people to be members of that group. In terms of triage oversight, Maryland provides a guide of who it is that is going to oversee this specific committee. And so it includes the chief medical officer, the chief nursing officer, legal counsel, risk management, someone from the chair from the ethics committee, and then one designated off-duty triage officer. And they're supposed to be reviewing that the decisions kind of make sense. Should we be changing anything? Pennsylvania doesn't really give, in their document, very clear guidance about how that triage group might be overseen. What comes out of the triage process is a point system. And the point system, the way that it's generally framed is that as you increase the number of points as the number of perceived risk factors goes up, and as those resources, as those risk factors go up, that person would receive lower priority to receive resources. So categories might include like inclusion and exclusion criteria, standardizing the scoring tool by age, is the patient pregnant or not, certain comorbidities, whether those are short or long term, we'll discuss that as well. And then some people, again, might give priority to those who are central to the public health response. Exclusion criteria is something that, again, the Maryland framework and the Pennsylvania framework they differ on. Maryland has exclusion criteria, so they say there are certain conditions under which your likelihood of survival is so low that they don't even put you into the triage allocation process. Pennsylvania, however, explicitly avoids having any categorical exclusion criteria because they really felt that that is going to send this message that some lives are not worth saving, and they were concerned that that would increase perceptions of unfairness. Additionally, so these scoring tools, Maryland and Pennsylvania, to a certain degree, use similar tools, but they're not identical. So in both Maryland and Pennsylvania, they use a sequential organ failure assessment, which is also what the original Stanford Office of Emergency Management guideline uses. For pediatric patients, both groups use the PLOD-2 score. In Maryland, they specifically use a SNAPPy-2 score and an NICH-DOT score for neonates. In the Pennsylvania system, critically ill neonates they say they're not candidates for aggressive resuscitation and ICU support if there's NICU scarcity. And part of that rationale had to do with how they were thinking about NICU ventilators in relation to adults. They also specifically talk about ECMO, that would be decided ad hoc by a triage officer with input from other clinicians. So again, if you want to review the current OEM guidance, it is available online. The initial version relied on SOFA scores. Both clinicians and ethicists at both hospitals have been working really hard to work to update this system because to make it more flexible for times like this, like a pandemic, when it's, I think we're all realizing the specific needs based on the type of disaster. In Pennsylvania, the way that the scoring system looks, I wanted to give you a sense of how points might be allocated to a patient. And so you'll see here in the Pennsylvania system, they are prioritizing what it is that saves the most lives, and then additionally giving additional points for saving the most life years. So they're adding major comorbidities would receive 2 additional points, severe life-limiting conditions would receive 4 points, and they do provide an example of what those might include. It's not an extensive list, so clinicians would still need to give some input. And this is an excerpt from the Maryland guide for adults and children. So whether it was the adult score or the SOFA score or the PLOD score, they tell you how many points a patient would be allocated. And they provided an additional point, 3 points for long-term survival. They don't specify, they only specify severe comorbid conditions rather than longer term prognosis. So the Maryland framework specifically prioritizes death within 1 year. And then they also do have a secondary consideration for life cycle. They use this more as a tiebreaker. Pregnant patients are another area that can be quite complicated because SOFA scores are not a great they're not a great tool to use for pregnant women for a number of physiologic reasons. However, both Maryland and Pennsylvania still use SOFA scores as a baseline scoring system for pregnant patients. And then for the third trimester patients, they have the OB evaluate for heart tones urgently. And if the fetus remains viable, then they actually change the points to improve the priority score for the patient. And they explicitly state that if either the fetus or the patient is unlikely to survive, they do not adjust the score at all. Pennsylvania also uses the same SOFA scoring system with pregnant patients. And then they say that they only say that if the patient has a viable fetus, then they improve the priority score. Both Maryland and Pennsylvania do provide some improvement in priority score for acute healthcare workers in particular. And this is just an example from the Pennsylvania protocol of, depending on how many points you had in total, you would be either prioritized as the highest priority, intermediate priority, or lowest priority. One of the things that's really interesting is that California, this picture is really all the guidance that is provided from California about how we should think about allocation systems in our state. So we don't have very clear state guidance on how it is we should be thinking about these issues, and we don't have uniformity across hospitals in California because there is, again, just quite a small amount of guidance. Next, I'm very excited to tell you about my colleague, Holly Tabor. She's been working with a number of colleagues from other organizations, and they've been working very hard to put together an analysis of many different ventilator triage policies. She'll be able to, I'm looking forward to that paper coming out in the future. Dr. Tabor is an associate professor in the Department of Medicine. She is the associate director of the Stanford Center for Biomedical Ethics, and she's my co-chair at the LPCH Ethics Committee. She's also the co-chair of the Stanford Healthcare Ethics Committee as well. She's an amazing person who knows a lot about disability rights, who I feel like I've learned an incredible amount from, and it's my pleasure to introduce her.
Thanks, Alyssa. So I'm going to try to shed some light on a particular challenge that's related to both the theoretical issues and the practical applications of crisis standards of care, as Dr. Magnus and Dr. Burgart have talked about, and really the impact of the potential impact of rationing of scarce resources on the disability community. So next slide, please. So it's possibly not new information to some people in this audience, but probably is to others, that in fact disabled people are already at unique risk in our society. There's significant evidence that people with disabilities, both adults and children, have significantly reduced access and barriers to healthcare across the board, and that these have very significant impacts on comorbidities and on life expectancy. So that's the context in which the things I'm going to talk about are happening overall. The other thing that we know for sure from empirical data is that clinician bias towards people with disabilities, all types of disabilities, exists and reflects the bias that exists in our society. And that's both implicit and explicit bias. And so again, that's a really important thing to take into consideration as we think about the unique features of the current situation and these crisis standards of care. This photo is from an article in the New York Times in the last week, talking about a situation in a group home for adults with developmental and intellectual disabilities in New York that was really savagely hit by COVID-19. And the article describes in detail what I just spoke about. Next slide, please. So one of the things that's emerged in the context of bioethics and medicine and pediatrics, but also in the media, is the idea that some of these crisis standards of care have significant challenges in the way that they think about people with disabilities. And here are some examples from Alabama and Tennessee and Washington. And both implicitly and explicitly, several of these policies specifically indicate that certain people with disabilities should not be receiving priority, or even sometimes potentially be be considered for allocation to scarce resources, including ventilators. And it's actually quite striking what some of the language of some of these policies are. And I just want to highlight again that even sometimes when this language is not explicit in saying that a particular diagnosis or condition would be excluded or population would be excluded, the way the criteria themselves are designed actually does disproportionately affect both children and adults with disabilities. And for all of these states and some others, there are actually active lawsuits going on to try to address these challenges. And we'll talk a little bit about that more in a couple of the future slides. Next slide, please. And really the reason why there are lawsuits is because due to a lot of tremendous advocacy work over the last number of decades, there are actually really important legal protections for the civil rights of people with disabilities. And these are some quotes from a really wonderful article that will be in our references by Ari Neiman, who's a visiting scholar at Brandeis and is also founder of Autistic Self-Advocacy Network, talking about the real fear that has been expressed by people with disabilities about what will happen in the kinds of situations that we're planning for that Dr. Burgart and Dr. Magnus discussed. And Ari goes on to talk about the fact that the civil rights don't go away and the civil rights still need to be taken into consideration, and that this is a really important thing for people to be thinking about. Next slide, please. The other important issue that's important not to forget is the fact that some disabled patients, both adults and children, actually already have ventilators. And if they come to the hospital, they may actually come with their ventilator. And there have been some discussions and concerns about whether or not those ventilators might actually go into some kind of allocation scheme or crisis standard of care and actually potentially be taken away from the person with a disability. And I'm not going to read these quotes, but Adrienne Ash, who unfortunately has passed away but was a wonderful bioethicist, talked about how a chronic ventilator is part and parcel of the person who has that ventilator. And Alice Wong, who's a really amazing advocate, talks about her vent being part of her body. And I think these are really important to think about and think about why we have to consider carefully how we want to approach the idea of people who come to the hospital in this situation who in fact have their own ventilators. Next slide, please. I think the other really important issue that's come up in a lot of the work that's been written about the concerns for people with disabilities and discrimination in the context of this crisis is that there are, just because these decisions are hard and tough and challenging, and just because there is a scarce allocation of resources doesn't mean that there aren't good ways to think about how to consider the rights of people with disabilities in an equitable way. And I think the second bullet here is the most important take-home point here, which is that there's substantial evidence that there's a difference between disabled people's self-assessment of their quality of life and the judgment of people who have never experienced their disability. And this is sometimes called the disability paradox. And this is, there's a lot of evidence to support this, both in society and medicine, that the perception of the quality of life is extremely different between the people who actually have the disabilities and the people who don't have the disabilities. And these are quotes from Professor Stramondo, whose picture and Twitter handle are on the right, who's written very eloquently about this recently. And I recommend his article listed below and in the references. Next slide, please. This is actually sort of somewhat surprisingly happening at a time when there's been sort of some increased attention paid to disability rights and the history of disability rights. Netflix just, I think 2 weeks ago, came out with the documentary Crip Camp, which was a wonderful documentary about some of the history of the disability rights movement, and particularly focuses on a group of people, including Judy Heumann, who's pictured there on the bottom, and the rights in particular for the implementation of Section 504 of the Rehabilitation Act in 1977, as well as the passage of the ADA. And it's a really wonderful documentary that really highlights some of the issues that we're talking about today. So I really recommend that, as well as the work of the Disability Rights Education and Defense Fund, which I'm going to talk about a little bit more. Next slide, please. So in the midst of all of this discussion and controversy about these crises of standards of care and their potential discriminatory and differential effects on people with disabilities, the DREDF actually issued a wonderful guidance on this, which it will be in our references. I'm essentially describing again and stating that healthcare providers in the United States are subject to the disability non-discrimination mandates of the ADA and of Section 504, and that categorical denial of medical treatment violates those laws, and then even facially neutral policies that disparately impact people with disabilities are also in violation of the law. And so they do a wonderful outline of what essentially the legal expectations are, even in a crisis standard of care, and how those might potentially guide how we think about these standards, crisis standards of care, defining them and applying them. Next slide, please. And in their recommendations, they make several explicit points, which is providers cannot deny or limit care to disabled people because of their disability. And we were talking about likelihood of survival. Dr. Burgart showed some different ways. Some of the survival documents have talked about 5-year and 10-year survivability, and there's sort of some discussion and debate about how accurately we can predict 5 and 10-year survivability for anybody. But providers cannot deny or limit care based on the fact that a disabled person may have a lower likelihood of survival. They cannot rely on quality of life judgments, going back to that point by Dr. Stramondo, that there's really a lot of bias about quality of life for people with disabilities. And they cannot deny or limit treatment to a person with disability because they may require reasonable accommodations. And I think that's really important as well. We don't have time to unpack that completely, but that's a very important and complicated point. Next slide, please. One of the things that came up even before we were invited to give this grand rounds, but especially after, several providers, including at our own institution, reaching out to us and talking about how parents, in particular of children with disabilities, were reaching out to them with concerns about access to ongoing care for their children with disabilities in the context of the COVID-19 pandemic. So this is less about whether or not they will actually get or not get certain treatment if they come in with COVID or suspected COVID, but how will they get their ongoing access of care? Will they be discriminated against for the care that they need? And I think this is a really important point. There's been a lot written about this, both by adults with disabilities and by parents of children with disabilities. And how can we think about our duties as clinicians and as providers and as institutions to provide ongoing care to our patients with disabilities? And this is a very important topic. Next slide, please. And so thinking about that and thinking about all the points I've just made, I just sort of, what are some take-home points about how we can do a better job and a more equitable job at developing and deploying a crisis standards of care? Next slide, please. So I think one of the most important things we can do is challenge disabled assumptions about the overall health status of disabled people, about their quality of life, and about their social utility. Again, thinking, applying a less sort of potentially biased, purely utilitarian argument that views the social utility of people with disabilities as being somehow less than. And this work comes from a wonderful article that we'll have in our references by Professor Scully at Newcastle University, who's a scholar on this, talking about this. Next slide, please. And she also talks about possible solutions, and she says critical care decisions should be based on the knowledge of the individual patient's personal medical history, not on the assumptions about quality of life. And really, that, as mentioned earlier, we really need ongoing transparency and community engagement, including with people with disabilities and families of children with disabilities. And really that all crisis standards of care documents should include an explicit non-discrimination statement. And this affects other populations too, but particularly for people with disabilities, as being worthy of care and valuable. And I will say that in our analysis of the existing crisis standard of care documents, it seems that it is a very small minority of crisis standard of care documents that actually include such an explicit statement or talk about disability in this way. Next slide, please. And I think, going back to the point about some of the concerns that have been raised by providers, we really have to think about how we can fulfill our commitment to and communication with patients and families with disabilities, about how we will provide ongoing care and reduce new barriers that may be occurring, and how we can consider on an institutional level how we can support people with chronic needs and disabilities. Next slide, please. And I just want to end my part with a quote from a good friend of mine, Paul Miller, who was a professor of law and also the former EEOC commissioner who passed away in 2010. And he was an activist as well, who was very involved in part because of his legal background and his work in the disability rights movement with the passage of the ADA. And this quote is from when he knew that he was coming to the end of his life, and he talked about sort of expectations of other people about what his quality of life would be like. And I'm not going to read the whole quote, but I just want to end with the last part he said, where he said, "I have had a marvelous life, and I just want my girls to know that everyone can and must live a marvelous life." And I just think that's a really eloquent way to frame sort of how we have to sort of think differently, think outside the box, and challenge some of our implicit and explicit biases about the lives of people with disabilities, and how we can develop, adopt, and implement policies so that we can do our best to serve the needs of those patients and of that community. Next slide, please. And the other thing that we are well aware of, and several people have raised to us, may come up in the Q&A as well, is there are a lot of ethics concerns involved in the COVID-19 pandemic. Here are just some of them. I talked about people with disabilities, but there's lots of other concerns about social determinants of health and other potential biases and different experiences, and a lot's being written about that. PPP access, duty to treat, a lot about palliative care and how we're going to do that, a lot about potentially elective procedures and surgeries and how we decide what's essential, how we serve the needs of patients who don't speak English, some of the economic impacts and public harms and even psychiatric harms of social distancing, and there are a lot of cost issues. We could do numerous more lectures on this, and I think there's a lot to talk about and a lot to write about. If some of the people who we've recommended potentially following on Twitter are people who are very involved, scholars who are very and activists who are very involved in some of these debates, and that's a good source for some of this information. Moving forward, as well as some wonderful articles that are coming out in journals across pediatrics, medicine, and bioethics. Next slide, please. So I just want to finish by thanking very much the Department of Pediatrics for the invitation for the three of us to speak. I want to remind everyone that the Ethics Consult Service can be reached through the pager, and we now have an ethics email that we're also monitoring, ethics@stanfordchildrens.org. You can follow some of us on Twitter, and Dr. Burgart has kindly made this QR code that you can scan, and you can get access to all of our references. So with that, I will pause and hand it back over.
Sorry, okay, am I good? So thank you all three. That was really wonderful. And as always, we will post this on the Department of Pediatrics website, make it widely available for people to share. And then I think we'll also ask if we can have your slides for the same reason, because the references are so wonderful. So we've got great questions coming through. There's a couple that are directed to specific speakers and others more broadly. So Alyssa, during such a crisis, does society's need for scientific data trump the right to autonomy in a patient who is unable to consent because of their condition? And for example, can research be performed on an intubated or sedated COVID patient to gather data?
That's a great question. I think we're seeing a lot of very interesting research ethics come to light in this pandemic. Typically, most research is not urgent or emergent. There's lots of research where there is time to have a very deliberative process with a patient. In terms of guidance on whether or not an intubated and sedated patient can be part of a research study, that's something that gets submitted to the IRB in terms of their plan as researchers and how it is that they would protect the interests of that patient. In many ways, just as intubated patients who are sedated are not able to consent for regular care, they also wouldn't be able to consent for research care explicitly. And so we would be relying on a surrogate decision maker, someone who cares deeply about that person to help make that decision.
Alyssa, could I just add, if for whatever reason it was not possible to get a surrogate to be able to give consent on behalf of a patient who lacked capacity and wasn't able to do so, there are a few different ways that can still take place. So in emergencies, it's not uncommon that you can't get consent. And so there are emergency waivers of consent that are obtainable, or if it is a minimal risk study, if the intervention is minimal risk, then it is possible under certain circumstances, and you have to meet certain criteria to get a waiver or alteration of consent in order for that to go forward. I also want to take this opportunity to just sedate, because it's a communication that went out to the chairs, but I'm not sure if it's been sent out to everybody. There have been so many people who are interested in doing clinical trials on patients with COVID, frankly, way more trials than there are actual patients that we have at Stanford, that there's now a committee that's been formulated that I sit on that makes allocation decisions about which trials are going to be allowed to go forward, and essentially allocating the patients to those trials.
Thank you, David. That's a really important point. And as well, Bonnie Maldonado and others are thinking about building infrastructure for that kind of research. So there's been an extraordinary number of studies that have already been proposed, and I know there's many more to come. So thank you for reminding us about that committee. Okay, David, maybe this is a good one for you. What are the effects of triage decision-making, including healthcare workers who know the patient, like if they're an MD, an RN, or a social worker who might have interacted with the patient prior to intubation and prior to loss of communication abilities? Should such people be excluded from triage?
This highlights something that I think is really important, and that most of the guidelines, including the overarching plan that's already in place and creates the overall structure that we would have medical center wide, is that this should not really be a bedside decision. Putting clinicians and physicians and nurses in the position of having to make those decisions about their own patients is something that's problematic. So you really want to have a triage team be the ones who make those decisions based as much as possible on objective criteria, using whatever the point scoring system is and whatever the allocation process is within categories in that point scoring system. So it really needs to be done by the triage officer and the triage team rather than a bedside decision.
Thank you.
Can I
Oh, sorry. Did somebody want to add something?
I just wanted to add that I think one of the things that we are thinking about and working closely with our colleagues on, though, is thinking about the situations in which providers may experience moral distress and moral injury related to all aspects of care, both for COVID-19 and for other patients. And even if they weren't involved in a bedside triaging decision, as I totally agree with David about, we're very aware that there will still be impacts on people, and we need to figure out how to support our providers.
Okay, so here's an interesting one about PPE. Unfortunately, we've been so lucky to have a really solid supply of PPE here. But so from an administrative level, what are the ethical and legal issues when providers are mandated to work and see patients without proper PPE? How do you weigh maintaining a capacity to deliver healthcare against maintaining the health of our workforce?
I think Alyssa should go first on that.
You know, this is something that I've thought really significantly about because I'm an anesthesiologist and I intubate people. And so, what you're highlighting with that question is the immense obligation that our organizations have to continue to provide PPE for us. I think, however, that we also need to think beyond our individual organizations to the role of both state and the federal government in terms of increasing supply whenever possible. So I just want to point out there are things that can be done even beyond the hospital level to help improve supply to reduce the ethical conundrums that take place at the bedside. One of the things that this comes up against is what is our duty to treat in the context of our duty for self-protection. And I think that there are some of us who are just at much greater personal risk than others. For providers who are significantly older and are just based on the data that we have about this particular disease are at expressed risk, or patients who have immunocompromised status, or they have children at home or partners at home who have immunocompromised status. So I think there's really something to be said about to what degree can we ensure that these risks are kept to a small group of people who are volunteers who feel that their risk is reduced and that they're willing to take some personal risk, knowing that if we ran out of PPE, that would change the paradigm.
And I could add one thing. I think it also depends on what the intervention is that's being that a patient is facing. So there are some policies and guidelines that have been developed. We've actually developed a few that have been put in place and accepted center-wide about, for example, CPR for cases where it's unlikely to be effective. And I would say, and this has been now in the literature, that doing CPR where the prospect of benefit is relatively low, and if there's no PPE, the prospect of harm to the clinician is very high, that would not be indicated. And so there can be some nuance around what particular interventions are being done. And then there's a lot more being done. We just heard a presentation this morning about some work being done to create safer ways of providing care using telemedicine, even inpatient.
Yeah, thank you. As I'm scanning these questions, I think there's so many where I'm sure we don't have sufficient data, and it's interesting to I'm going to ask one of my own, and are there efforts away maybe in cities that are really resource challenged to collect data that might answer some of these questions? So I'll tell you the question that prompts me asking that. So previous studies have indicated the age of the MD as a determinant of how they weigh the value of life expectancy. For example, the value of additional year of life resulting from treatment is assessed differently by young, middle-aged, and old physicians. What are the effects of the age of the triage team members on decision-making for COVID-19? So I'm going to go out on a limb and say you don't have the data to answer that, but you may. And then also, is there a way to collect those data so some of those questions can be answered?
That's very interesting. I don't know if anybody's studying clinician attitudes about those trade-offs, but there's been a lot of study. I think Alyssa mentioned some of the work done at Maryland that Lee Dougherty did, where they were looking at some of those ways people look at things. But I have to say, going from empirical data about people's views to practice is very challenging, because even the data from Maryland, which showed a lot of support for the triage plans they had among the African Americans in those studies, they actually did not view it the same way as the majority did, and that became the state policy. The African American communities that were represented in that data showed that they preferred first come, first served, rather than approaches that were a little bit more utilitarian in approach. So I think I think there's a lot of evidence to support that there's variation across different groups, and including groups of physicians, about how they, in general, they view the value of life. There are religious differences. Physicians have been studied in terms of religious preferences that physicians have, and in terms of that, how that influences their attitudes about the value of life and other kinds of end-of-life decisions that make a difference. So all of these are filtered in a lot of ways, but going from the heterogeneous views and the factors and understanding those to figuring out what an appropriate policy is actually another step that can be actually very complicated.
I think there's a lot of data about implicit bias in general, and how implicit bias works, that suggests the best way to minimize bias, both implicit and explicit, is to design systems that it sort of essentially trick and sort of manipulate it so that certain kinds of biases don't go into, as much as possible, decisions that get made. And of course, that's challenging to do, but there's some examples of other kinds of situations where that's been successful that we can probably learn from.
Yeah, thank you. So early on, I saw some fake news that BMI was being used as a criteria in Seattle. So shortly thereafter, when Lee Sanders sent me some other documents that some other disabilities were being considered, I assumed that wasn't real and Googled it. But I found then, and you've shown as well, that there are states that have been using, have been taking some of those things in consideration. So let me ask then, so Lee's question is, in addition to disability-related disparities, we are already seeing disparities related to racial, ethnic, and socioeconomic status. And I actually think that's a big part of the news coming out of New York. And so with respect to accountability, how do we ensure these characteristics are addressed during the pandemic, particularly with regard to allocation of ventilators and novel treatments, both clinical trials and then including vaccines?
I think that's a really important question, and thank you, Lee, for raising it. Dr. Fauci talked about that, I think, 2 days ago, and comparing it to some of the health disparities that were revealed in the HIV/AIDS crisis and his particular role in that, and his sort of looking at how some of the disparities, particularly he was talking about race, are already occurring and are likely to occur in the future as well. So I think there are probably different tiers of things we have to do, but one of the things I think we have to do is continue to do research to look at the impact of different factors and existing health disparities on access to care and on outcomes as a sort of ongoing moving target, so that we can try to identify and address the disproportionate effects as they're happening. I also think it goes back to transparency and community engagement. I think there are ways in which we make and have made efforts to do that, both at our institutions and at other institutions, but I think this is another call that we actually have to think about how to include those communities in thinking about some of our decisions, and having transparency about that. But I do think this is going to be an absolute sort of crisis call to action about some of the ways in which our society still has significant health disparities in ways that people are already starting from a place with more risk factors for poor outcomes, but may get less equitable treatment, even if it's not explicit and conscious, and may have other long-term effects as well. So I think it's a very good question and point.
Can I just add that I think it's really important to distinguish between a fair process and what happens in terms of outcomes? Because even when you have a fair process in a society in which those inequalities exist at baseline, a fair process can still result in unequal outcomes. in the population. And arguably, there's a duty to try and do what we can to try and ameliorate those. And I think Rawls certainly would say that we have an obligation and duty to particularly be attentive to the needs of those who are at the bottom. But I think it's really important to distinguish between those two, because some of the allocation schemes, some of the ways that people are thinking about things, as Holly was talking about earlier, create more opportunities for the implicit bias to come in, whether that's about people with disabilities, or their same data shows that there are biases against people who are poor and for different racial groups. And when you create space for those kinds of biases and the judgments to take place, then you have an unfair process. If you can try and mitigate those, that makes things better, but it doesn't guarantee that you won't have discrepancies in outcomes. And that requires other kinds of actions.
Well, and to take it to a very practical level, these are big, huge issues that have been pervasive in our society and are going to continue to be pervasive in our society until we make significant changes. I think in terms of rationing today, right now, if we went into a crisis standard of care, this is where we really have to think about those charts that I showed that come from these different places. And when you start to take into account longer and longer prognostic considerations, if you stick with how likely is it that this patient will survive this hospitalization, it does help minimize certain biases that are baked into 10-year survival prognoses. And so I think that that's something that we have to think about really concretely as we move through this process, and moving beyond it is how can we ensure, as David discussed, that a fair process exists, and how can we adjust the process now to minimize the problems.
So David, in your role, on the committee for all the COVID research that's going on, I've seen emails about creating pediatric registries, and I've forwarded that to some people that sort of oversee some of the registries here. But I'm wondering, when that comes to you, or if it does come to you, or in other studies, are there opportunities for you to suggest additional data they might want to collect that might help, for people who aren't thinking about the ethics piece, that might help do some additional analyses related to some of the questions that have come up today?
Yeah, I think it's really important that all of these committees have a lot of different people with different backgrounds on them. So Stanford's trying to create a very large database, a large biobank, Stanford-wide for COVID patients, so that to be able to make that available, and especially for things involving biobanking, there's going to be just a limited number of aliquots, and given the number of labs that want access, it may not be possible to give access to everybody, but a lot of those studies can be combined. There's no reason why sequencing and a lot of the assays and studies have to be done over and over again by different groups, so as long as there's adequate data sharing. So I think there's a lot of push in that direction of creating a single large unified biobank and deciding who gets access and trying as much as possible to combine people. For the outpatient survey research that's going on, which there's a lot taking place there to try and learn more about what people are experiencing and what people are going through. Similarly, if everybody sends surveys to all the patients, all the parents of patients, we're going to be they're going to be overwhelmed with surveys. And so similarly, there's an attempt to try and get those things coordinated so that we can get those research efforts done in a unified fashion. But I would say there's a large group of, not just me, but a whole bunch of people sitting down together trying to think about, like, what kind of research do we need to have take place to help answer the questions that we need in this research.
So oh, sorry, please.
Oh, I was going to say, additionally, for any researchers who are listening in, the Stanford Center for Biomedical Ethics also has a research ethics consultation service. And so if you're working on a project and you think there might be an ethical question here, we would be happy to talk with you about it, to go over it with you, and help in any way that we can.
Yeah, thank you. I think as I'm sure now who has access to testing is, rampant with bias. But I'm thinking as people are starting to shift to population-based studies and going out into the community, that would be a good opportunity. I know there have already been some pretty large-scale studies out in the community here, and I don't know, David, are they collecting those data in a way that's completely de-identified so that there's not an opportunity to ask these questions? Or, can the kind of stuff David Rakoff does with, geography and other considerations be brought to bear on some of those studies?
Yeah, that's a great question. I think it's variable right now. So there's at least 3 or 4 kinds of studies that I'm aware of. Some through My Health and similar portals to get questions to people. Some for surveys that are being sent directly to people. Lisa Goldman Rosas has been leading a lot of the efforts around trying to coordinate a lot of those efforts. I think most of those are attempting to do things in a de-identified fashion under their IRB, but obviously the My Health ones are probably not. So I think it's highly variable in terms of, and it depends partly on what they put into the IRB.
Okay, thank you. Our speakers all agreed to run a little long because we anticipated great questions. Thank you first for providing, you're so much time for questions. So I hope we can get to all of them. Holly, I have raised questions about our hospital's plans that mention a way tie breaking that would deprioritize people who cannot perform more than 3 activities of daily life. The pushback I got is that there are data, which I've not seen, that show that these limiting conditions are associated with very prognosis. I can see the reasoning behind this, but still sense there is some unfairness here. What do you think?
So I don't know who the person saying the question was, but that is not currently part of the tie-breaking criteria. Alyssa and David can weigh in for either of our implementations of these policies. And I think it's a very good point that mentioning activities of daily living puts on a particular framing of what quality of life looks like for certain populations over others. And it's certainly one of the criteria that's been most questioned and debated, and both in terms of explicitly, as that questioner described, but also in terms of implicitly by saying sort of quality life years and what are the definitions of different quality life years. I personally am in favor of trying to be as evidence-based as possible. And my view of evidence is evidence that actually takes into consideration potential biases and disparities in the way we view quality of life and other kinds of outcomes for people with disabilities. I personally am more in favor of things that focus on sort of hard data around survivability, closer to 1 year survival or survival to discharge from the current illness for ventilators. But I think the debate is really important. And I have to say that there's been a lot of really good discussion just in the last 2 to 3 weeks across the field about how to think about exactly the kinds of questions that the person raised. So I don't know, Alyssa or David, if you have more you want to say about that.
I think you captured it. We definitely, I don't think that anything like what was just mentioned is anything that we're talking about. And in fact, I think our criteria, we're trying to avoid as much as possible any kind of approach or criteria that is amenable to bias in the judgment. So exactly what you said, focusing on the things, on the outcomes that are as evidence-based as possible and associated with both immediate survival and 1 year survival, and even the Pennsylvania guidelines, which have 10 years, and Doug White, Bernie Lowe's JAMA piece, their model policy, which says life-limiting disability and 10-year survival. I think the general consensus that we seem to have is that that's a problem.
I think that's another reason why having explicit non-discrimination statements at the beginning of the policy, front and center, is also really, really important.
Yeah, thank you. So when Lee and others brought some of these policies from other places to our attention, some of that was sent to us from our families and our patients. And I think trisomy 13 and neuromuscular diseases were some of the ones I remember seeing. So Mimi from pulmonology, her question is, based on the policies in other states that specifically name diseases for exclusion of treatment during COVID-19, the parents of pediatric patients with neuromuscular disease and chronic ventilation here in California are very fearful. What are the policies in California and our institution? And then I think a really important question is, this information would be helpful as I talk to these families and the foundations that advocate for them, and maybe how can we push this information out to these communities?
I'm going to let Alyssa answer, but I'm just going to say I completely agree that transparency and communication about this is absolutely critical, and we're getting that feedback from families too. I think it's very important. Alyssa, why don't you talk about the Packard policy?
Yeah, Dr. Booth, thank you so much for your question. We are very explicitly in our conversations at LPCH talking about ensuring that our guidance very explicitly does not include exactly those sorts of diagnoses. We are eager to ensure that we have evidence-based guidelines that ensure that we are using scoring tools that do not treat children who have life-limiting illnesses that are chronic in that way, because we want our parents to know that when they come to us with their children, that we are going to take good care of them. And an additional issue that we didn't talk about extensively in our talk previously is that we're not in a crisis standard of care right now, and so we want parents who have children who need health care to come and see us. We do not want them to suffer unnecessarily because their parents are afraid to bring them in. And one of the other issues that we've been talking about in terms of our allocation guidance is, I'm really promoting that we should purposefully make it public as soon as we're able to, because we want families to see what is the process that we're proposing. These are the things that we were concerned about in terms of bias, and these are the things we're doing to reduce that risk.
And can I just add one thing, which is I completely agree with everything that both Holly and Alyssa said, and I don't think we will try and get those out as soon as those are finished, and so I don't think people need to be fearful at Stanford or at Packard. However, we cannot speak for the state of California, and you expressed a concern that some families are expressing, not just about us, but about the broader context in which this is occurring. And as Alyssa showed in her slides, the guidelines for California are very sparse, and there's going to be a lot of variation across hospitals. And I don't know that we can say that at Oakland Children's or at UCSF that they're going to follow policies like ours, and that they may very well face discrimination if they adopt some of the model policies, for example, that have been.
Although that's a very good point, David. I am really hopeful, though, that parent advocacy, adult advocacy, the advocacy of these rights organizations that are filing lawsuits, there was even some Department of Health and Human Services guidelines issued about this that were somewhat reassuring. Plus, actually, I think not just communicating to patients and families, but I hope discussing how we developed our policies and why we did it the way we did it publicly may actually lead to change from some of the other policies at other hospitals and other states that may be potentially really fearful for these patients and families. So I think it's a moving target, and we need to continue to do continuous improvement like we do in everything else in healthcare.
Yeah, thank you. I mean, it really strikes me throughout this entire presentation that a real value of this is that we've elevated and educated our community about the work that all of you are doing. And I wonder if there might be an opportunity to take this video and send it to some of your ethics colleagues to other places in the state and get some information about how they're thinking about these things. Okay, a couple more. What happens later in retrospect when in a crisis situation, a doctor makes decisions that are inconsistent with the algorithms?
Yeah, so if to some extent that's not different than non-crisis situations, right? So clinicians make bedside decisions based on what they think is best for the individual patient, and we know that there can be bias in those clinical judgments just like anything else. And so if the triage says this person is a priority and an individual clinician in their judgment says I'm not going to do that, I think that's something that would require after action review, just like any other decision that they make without a crisis standard of care. If a clinician decided to unilaterally withdraw ventilatory support on a patient against the family's wishes now, there would presumably be some kind of review process for that as well.
Yeah, thank you. Okay, we're in the home stretch. How do we resolve the limited availability of resources in this is a hard one, in a pandemic with a long history of bias, bigotry, and racism in this country, which is still rampant in some states? I might add all states. Sorry, this is a tough one.
It is a tough one, and I think that's actually an incredible opportunity. And I was really moved by what Dr. Fauci said the other day about that, and about the ways in which tragedy and crisis in the HIV/AIDS pandemic led to really thinking differently about some of the disparities and biases and discrimination, and have a moral obligation to embrace the opportunity, even if we are in a location.
Well, I agree for grand rounds. I think I agree with Holly. This is an amazing opportunity. We absolutely want to make sure that we take this motivation and we move it forward, both through policies at our local hospitals, but also in the greater government. Dan Goldberg from University of Colorado gave an incredible talk a couple days ago on systemic bias and social bias, and how it is that we can use policies to effectively ameliorate that at a higher level. And I think we should really aim for that.
But can I just end on a little bit of a downer note, which is that These issues
Great.
are actually
Yeah.
very challenging, not just because I think there are definitely, I completely agree, ways in which we can use this as an opportunity to improve things and make things better. But in some of the work that a group of us have been doing on AI and bioethics and its use in clinical care, it's really challenging when there are actually, given the existence of health wealth gradients and racial disparities in outcomes, when you even rely on good objective data, you're going to wind up having differential outcomes on different populations. But it's not obvious that the right solution to we can try to ameliorate that as best we can, but sometimes it's not clear what the obvious solution to that problem is, because taking somebody who's very unlikely to survive and pretending that they aren't doesn't necessarily do them a favor, at the same time that that person is much more likely to be in that class and be critically ill as a function of racial and ethnic or socioeconomic disparities. So I think really ultimately what it highlights is not just that we need to fix the bias problem, but we need to fix the social inequalities that underlie these differences that are really the root cause of the problems.
Yeah, no, thank you. Okay, we're gonna try to just see if we can wrap this up. So trying to see, you've touched upon a lot of these things, and well, first of all, let me say that we had almost 600 people during this, and we still have almost 300. So I think that for that reason, I'm gonna just try, I think people are on, I'm gonna stick it out to the end. So let me try to do a few more if that's okay. I think we can get all of them. This has always been the paradox of practicing medicines. Doctors don't treat society, they treat individual patients. When a patient comes to you, you do the best you can. You don't shunt them aside. How do you change this conditional behavior? If you want an objective set of criteria for doctors to follow, we need a session in which you tell us how to change our behavior.
I think as someone who majors in undergrad in history of medicine and history of science, I think there's a lot of examples from the history of medicine and science of that tension that the person who wrote that question is talking about. I think there are some examples where we've treated more than just the individual in front of us, but I also think that there are lots of ethical reasons why we often have to look at the patient in front of us, as we've argued throughout the talk. So I think there is a place for some explicit education and training around that, but I also think it's less clear to me personally as a dichotomy between one or the other. I don't know, Alyssa, if you have thoughts on that.
Can I just say something quick? I think it's really important to distinguish between the bedside, where we want physicians to be focused on the patient, and higher level systems that make allocation decisions. I think forcing physicians to make those decisions for their individual patients puts them in an impossible situation. They should be advocating for their patients. But there are already a million ways in which clinician behavior is constrained, whether that's formularies or pathways or all kinds of things. But that's not something that we do at the bedside. That's something that happens at a higher level. That should not be up to the individual clinician or to be forced to making those decisions. They should do what they can for each individual patient, but they will be constrained just like they're constrained by formularies and other kinds of things that are put in place at a higher level. So you don't want rationing at the bedside. You want that to be at a little bit higher level than that.
Well, I also think that the commenters and their question really highlights this relationship that as physicians we have with our patients and these people that we care very deeply about, that we want to see survive and thrive. And when we're thinking about true austerity in terms of resources, it really shines a light on that relationship and how tenuous it is and how much it's based on what resources we have available. And that anxiety is very warranted. I feel it myself as well. And so again, I think this, as David said, we want to continue to advocate for our patients, and no physician taking care of a patient is going to be the person who's filling out those diagrams, circling how many numbers are going to be assigned to a patient. It would be totally inappropriate.
Yeah, I think something that I should have said maybe from the beginning is to help give some of our viewers some context who aren't up to the minute on what kind of numbers we're seeing here. We've only had 2 patients since this started who've been COVID positive in the hospital. One, I think, was a 6-month-old who went home within a day, and another one is a more chronically ill patient who was positive but now is negative. The adult hospital, I think, peaked at about 20 patients in the patient side, but we have not intubated a patient in 11 days. So I think that's just important for people to sort of understand about the things that we are grappling with here. I don't think there's been any issues. We were able to double our ICU capacity from something like 80 to 170 ICU beds had the need been there. And there obviously hasn't. There was a surge team that was activated a week ago today and then subsequently deactivated. Okay.
Very lucky.
Yes.
Well, I think that public health measures have been very, very effective here. And we are seeing the benefit here that, we worked very swiftly in our area to try to, work solidly on social distancing, conserve PPE, gather resources, and we've been very, very fortunate. And I think a lot of us in many ways feel guilty about other areas in the country that are not so fortunate.
Yeah, and I think it's tragic when we keep hearing the stories of the people on the front line, some who we were doing some really heroic work who've died. Even just in transplantation, the site where it was on one of the websites that listed a number of transplant physicians who've actually died. I think it's important to note that of the healthcare workers that have tested positive here, and we've been very transparent about those data, we believe they all, as best as we can tell from contact tracing, were got COVID on the outside, that this was community transmission, and hopefully it's reassuring that we have no instances here where we've been so fortunate with PPE, and so to the best of our knowledge, we haven't had a single COVID acquired infection within our campus. So we've been so fortunate, but let me refer to a question that was from the Ebola outbreaks, where the high loss of healthcare workers was devastating by both decreasing the number of available providers and demoralizing the remaining members of the team. And I think I would add that that's happening on the East Coast. Yeah. Should the survival of healthcare workers trump all other considerations?
Can I say something else about that real quick, which is in some of the debriefings we're doing on the adult side, I think it's absolutely true that what's happening in other parts of the country and the world is taking a toll on the emotional well-being of some of our providers. So I think it's important to recognize that, and for people to be have access to the kinds of resources for resiliency and wellness that we need to try to take care of our workforce and to keep going and to take care of ourselves. So that's a little bit different than the question I think you just ended on, which is about priorities for healthcare workers. So I could talk about that, but Alyssa or David, you might be better. Does one of you want to talk about that?
I think it really depends on the nature of the crisis, right? Because there is a big difference between Ebola, and especially taking place in the context in which those occurred, where the healthcare workers were the scarcest resource. More than PPE, it was the healthcare providers, and it was absolutely critical to both maintain them because of the role that they would play in providing care in those contexts, as well as to ensure that volunteers coming in from outside were going to be taking care of people in those countries. And so although there was some controversy around that, for example, giving the ZMAP to healthcare workers was really, I think, justifiable. And I think most of the ethicists who've written about that thought that was really appropriate. That might be very different from a pandemic that takes place in a US context, and in which the providers who get sick are unlikely to be able to take care of other patients. There still could be an obligation in terms of reciprocity, but at least some of the arguments in terms of resources may not be as applicable as they would as it was in the Ebola crisis. And of course, the risks of exposure are much less. So all of those, I think, factor into deciding whether or not you're going to give points, or if so, or take points away, rather, in the allocation systems, and how you take points away for providers, or whether you use it as a tiebreaker. And it's been variable about how that's been done. I think for the current crisis, in our context, as Mary said, we're not anticipating needing to do this at all. And I think the first thing to start with, and it may be not just here, but even in the places that are hard hit in the US, that if we just don't use ventilators in cases where it's highly unlikely to be successful, bordering on futility, if we just to take that step, that's probably going to be enough in most jurisdictions.
Yeah, I mean, I think it's very sobering to, if you go back and look at last Friday's grand rounds, which is about, advocacy, policy, community engagement, where disparities was a huge part of the presentation. Paul Wise presented, just how we are on the cusp of just incredibly devastating outcomes in Africa and South America and other places, the disparities that are already so rampant there are just sort of going to explode. Sorry, so I don't know if you wanted to say anything about that, and then we're so close to being done.
No, I agree. And in a country or a place where you have one physician per 100,000 people, the physician is an incredibly important resource that needs to be treasured.
Yeah. So, no, thank you. And then, so one of these questions echoes this issue about the risk to resuscitation teams. Again, I want to tamp down the fear here. We don't think that risk is such an important concern, but it does say that given most pediatric and COVID-19 arrests are due to respiratory failure, how should we balance the poor outcome of arrest patients and the high risk to resuscitation teams, even with compression-only CPR? And I just have to editorialize that we have very thoughtful evidence-based PPE guidelines here that are stratified very much by the risk, the intubation, those kinds of things. The question though is, are there national guidelines?
Yeah, and I should say that with proper PPE in accordance with CDC recommendations, that the risk of intubation is not, and even CPR are seen as moderate, not high risk procedures.
Yeah, no, thank you. I think our ENT surgeons who are really up in there doing things that might be aerosol generating, they really have been at the driver of a lot of our discussions around PPE. Okay, two more. Actually, one is a comment and one's a question. What are the ethics of the federal government to withhold ventilators and PPE distribution to the specific states?
Well, I think it would be in the country's best interest for our nation's leaders to ensure we have access to all the supplies we need to take care of our population. They have immense legal abilities to resolve many of these issues in terms of getting companies, compelling them to make ventilators, compelling them to make more N95s, compelling them to make more medications if we're going to have medication shortages. So I would argue that our social contract with our government would imply that they have an ethical obligation to help mitigate the crisis that's happening in our country.
Yes, thank you. So we still have a couple hundred participants, so we're just going to end on an important note, and that is, first, do no harm to yourself. Stay healthy and protect yourself. Stay home when you can. Telemedicine when possible. And I just want to congratulate Natalie Pagler and others for the degree to which they brought telemedicine into the inpatient service, and having iPads and things set up in the patient rooms that have really optimized the ability not only to protect ourselves by staying home, but to protect us while we're here. So I think I'll stop the questions there. Actually, we got to all of them. And just ask if there's anything you want to say in closing.
No, thank you so much for having us. We think we obviously feel really passionately about all this information, and we're happy to share it, and we appreciate you giving us a forum to do so.
Yeah, no, I'm very grateful as well that we had the opportunity to bring you here. So long overdue, but certainly at a time when you've got a lot of very engaged audience members. So
Thank you.
Thanks.
All right. So
Thank you everyone for your time.
Yeah, no, thank you. We'll make sure that lots and lots of thank yous coming in. So we'll again, thank you, and we'll make this video available soon, and you can help send it to your colleagues who weren't fortunate enough to watch this morning. All right.
Thank you.
Thank you very much.
Have a nice weekend.
Bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.